Our aim today is to cover the AUA guidelines on testosterone deficiency. And, there's a lot of interesting, but also some nuanced statements and guidance provided in the guidelines document. And we're going to cover the guidelines from a few different stances today, and hopefully have some good discussion along the way too. And these are my disclosures. And in the Division of Andrology, just a brief introduction. So I'm Robert Brannigan, the head of the division. Dr. Nelson Bennett does a lot of sexual medicine and penile surgery, implant surgery, and is a long-time member of our department. Dr. Josh Halpern is an andrologist, does a lot of microsurgery, male infertility work, and has done a lot of innovative work in clinical research, and really cares a lot of the clinical research for our department on his shoulders. Dr. Chana Amarasekara did a fellowship at Rush with Dr. Larry Levine, and has brought a lot of expertise with penile reconstruction and Peyronie's disease, as well as gay men's health to our department. And finally, Dr. Solomon Hayon is our fellow and just an outstanding individual in every way. He'll be starting at MUSC in August with his new faculty position there. So, testosterone has been talked about a lot in the literature over the years, and I think a lot of our patients are interested in testosterone therapy and how it might help improve their quality of life. I think there's a lot of controversy behind it because of unknown health effects, and also, the perspective of some clinicians that, maybe this therapy isn't necessary. Maybe men should just accept aging as a normal part of the life process. It is interesting if you do a Google search, these are some of the images that pop up. Even pretty recently, a doping scandal in the world of bridge. Bridge players even getting an edge on their performance during competition with testosterone therapy. So it is a banned substance in that particular competition or sport. So regarding the guidelines document for testosterone deficiency, for these guidelines, there's a statement of need that is kind of the run-up to guidelines document being committed to by the AUA or other organizations. And for testosterone deficiency in the guidelines, these are the statements of need. We know that testosterone prescriptions have tripled in recent years compared to really going back to the 90s, when there was very little of this going on. There are many men out there using testosterone without a clear indication. 25% of men on testosterone therapy never had a testosterone level checked. And 40% of men that get this therapy have no follow-up, no clinical follow-up, no follow-up labs performed. And 1/3 of men on therapy really don't meet clinical criteria to be on it. The other side of that coin, though, is that there are many men in need of testosterone therapy who are going undiagnosed, who are suffering signs and symptoms, and are not receiving therapy. This has led to the formation and proliferation of anti-aging and low testosterone centers around the country, and we certainly have no shortage of those in Chicago. And simply stated, our field was really in need of guidance. And I would point out that there are other organizations, for example, the Endocrine Society, that has come out with guidance documents, but this really didn't cover a lot of the areas that are relevant or germane to us as urologists that provide more comprehensive men's health care. And so this guidelines document was published in the Journal of Urology in August of 2018, and these are the participants for the panel. It was a very well-rounded panel, and I give the AUA credit because the panel in this instance and in many other instances was comprised not only of urologists, but also other individuals who are stakeholders in the care of men with low testosterone. That includes endocrinologists. Obviously, there are epidemiologists, as is usually the case, and also, Dr. Marty Miner is a primary care physician or an internist. And so, there was a diverse group of individuals in terms of their clinical background. I should also point out Dr. Kurtz, a cardiologist, is also on the panel. So, good representation from different disciplines within medicine. And so, while I don't have enough time today to overview the entire testosterone deficiency document, we did think that we would focus on the diagnosis of low testosterone and testosterone deficiency. They're two different things. And then talk about some challenging case scenarios, including the cardiovascular statements, the fertility statements, and then a brief discussion about prostate statements. And so to start, the definition of low testosterone, this key statement that clinicians should use a level less than 300 nanograms per deciliter as a reasonable cutoff in support of a diagnosis of low testosterone. And so the rationale for this was that there are a series of randomized controlled trials of testosterone therapy that used a cutoff of less than 350 nanograms per deciliter as inclusion criteria in these trials. And the panel, also looked at these studies and found that the median baseline total testosterone level among participants was 249. And so literally the panel drew a line in the sand. And that 300 number has also been put forth by various labs in the past. And the panel felt that this would be a reasonable cut point between low testosterone and normal testosterone. Interesting point, the panel came out against recommending the use of free testosterone as a primary means of diagnosing testosterone deficiency. And the reason for that is it's just not a reliable parameter. There's a high coefficient of variation for the measurement of this particular parameter. And really, there are not well-defined cut points for normal and abnormal for free testosterone in the published literature. So also, the panel then stated that the diagnosis of low testosterone should be made only after 2 total testosterone measures are taken on 2 separate occasions and both conducted in an early morning fashion. So we know that peak testosterone levels occur typically between 3 a.m. and 8 a.m. And levels after 4 p.m. are typically going to be lower, or late day values are going to be much lower. If we look at men, younger men tend to have more variability in their testosterone measurements compared to older men, where maybe the variation is only about 10% between an early and a late measurement. Another reason for having 2 measures is that there's a high intra-individual variability. And so really, this is an important issue if we're going to be starting someone on testosterone therapy, this medication. Having those 2 measures to confirm the diagnosis is important. In Europe, the guidelines state that patients need to be NPO before having the serum testosterone level drawn. And, the literature on that is really not strong. And so here in the United States, the AUA does not recommend that the patients be NPO before testosterone draws. An important point that is sometimes overlooked is that we really ought not check testosterone levels on our patients during an acute illness. These patients will often have some degree of suppression of the HPG axis, and this can lead to a transient decline in testosterone levels. So regarding the diagnosis of testosterone deficiency, this is a clinical diagnosis, and it's only made when patients have both low total testosterone levels and symptoms or signs of low testosterone. And so it's important to realize that a lot of these symptoms are nonspecific, and they might be related to conditions other than low testosterone. Many of our patients, have stress, anxiety, depression, and, these conditions can certainly lead to, fatigue and kind of feeling blue or feeling low. We need to keep that in mind when we're considering starting someone on testosterone therapy. So, the physical exam should be targeted and should definitely look at body habitus, looking for decreased virilization, potentially increased BMI, gynecomastia, testicular size, consistency and location, the presence of a varicocele, and prostate size and morphology. And so, these parameters are going to be helpful, again, in maybe understanding a little bit more about the degree of a person's, symptomatology with low testosterone. The guidelines document does state that, there are certain high-risk groups that testosterone replacement therapy should be considered for, even in the absence of signs or symptoms. And this would include patients with unexplained anemia, bone density loss, diabetes, exposure to chemotherapy, exposure to testicular radiation, HIV/AIDS, chronic narcotic use, male fertility, pituitary dysfunction, and chronic corticosteroid use. So again, even in the absence of symptoms or signs, given the high prevalence of testosterone deficiency seen in these conditions, testosterone levels should be measured. So the guidelines also weighed in, like, where should we target? What should we be aiming for in terms of a serum testosterone level once we start therapy? And there's a lot of discussion, thoughtful discussion amongst panel members regarding this. And the guidelines document at the end of the day stated that testosterone therapy dosing should be aimed to achieve a total testosterone level in the middle tertile or the middle third. And this equated to then a serum testosterone level of 450 to 600 nanograms per deciliter. And, this was really data, or this was guidance extracted from randomized trials showing benefits of testosterone therapy, where the median post-treatment total testosterone levels were 490 to 607 nanograms per deciliter. So let's talk a little bit now about testosterone and cardiovascular disease risk. And we're going to frame this in the context of a case. So we have a 50-year-old male who has a 12-month history of decreased energy, depression, irritability, and low libido. This man has a history of hypertension, dyslipidemia, and metabolic syndrome. He's married, he's a banker, he's a non-smoker, and he just has a mild use of alcohol, less than 1 drink a day. He does have a family history of premature cardiovascular death in his father at the age of 53. And if we look at additional reviews of systems, he has poor sleep habits, no chest pain or shortness of breath or other anginal symptoms. So on exam, his blood pressure is very high, 140/95. His heart rate is 76. He's obese. He weighs 240 pounds. He's 6 foot tall, and he has a BMI of 32 and a waist circumference of 42. So his weight is primarily distributed in his abdomen, so he has this predominant central adiposity. He has no gynecomastia and no testicular or prostate abnormalities. On lab testing, his H&H are fine at 15 and 45. And his first early morning testosterone came back at 240 and a repeat came back at 248. So both of these levels are low. Additional blood work showed total cholesterol of 240, HDL of 30, which is low, and basically some dyslipidemia going on in this patient. His PSA level was low at 0.4, and the rest of his HPG axis was all normal. And so, the next question is, what is the next step with regard to management of his low testosterone? And the guidelines advise as a first step to advise therapeutic lifestyle strategies as a first step. And these lifestyle changes include initiating aerobic exercise, including a total of at least 150 minutes per week, weight loss targeted to a BMI less than 25, and improved sleep hygiene. Impaired sleep hygiene does seem to contribute adversely to testosterone levels. And so after 6 months, this man represents, and he does have improvement of his blood pressure. He's lost 20 pounds. His BMI and waist circumference are down, so he's definitely making progress. And if we look at his fasting lipid profile, we find that there's improvement there, but his total testosterone still remains mildly low. And while he's had some improvement symptomatically, he still has decreased energy, he has depression and irritability and low libido. And so he wants to know, what are additional steps I can take? And so at this point, then, we would want to consider starting him on testosterone replacement therapy. The guidelines note, though, that the clinician should inform the patient at this time that low testosterone is a risk factor for cardiovascular disease. And this is particularly relevant for this patient who has a first-degree relative, his father, who died early at the age of 53 of a heart attack. And so, we do know from the abundance of literature that's been published that low testosterone levels are associated with an increased incidence of major adverse cardiac events. And this includes MI, stroke, and, even sudden death. And so low testosterone levels are also associated with an increased prevalence of atherosclerotic cardiovascular disease risk factors. And this includes insulin resistance, hypertension, lipidemia, increased BMI, and obesity. And so we need to talk to our patients about these risk factors. Now, obviously, some are fixed. So older age and male gender or male sex, we really can't do anything about that. But there are modifiable risk factors that patients can take action on, including the dyslipidemia, hypertension, diabetes, and cigarette use. So, there is an opportunity even for us as urologists, not to where the primary care doctors have too much, but to at least begin a discussion about these matters and encourage them to engage with an internist, and if they're not already doing that. So also, prior to initiating treatment, clinicians should counsel patients that it cannot be definitively stated whether testosterone increases or decreases the risk of cardiovascular events. So there are studies that have been published that measure cardiovascular benefit and harm. when testosterone therapy is given. And these results have really been inconsistent and frankly somewhat controversial. And so it's important, our patients are often asking about that. One thing that is clear, though, is that the current literature consistently shows that untreated low testosterone is associated clearly with an increased risk of MACEs. Again, that's major adverse cardiac events. And so when we look a little bit more closely at the literature, we find that in general, the randomized controlled trials on this topic show no difference in the incidence of MACEs, whether testosterone therapy is given or not. But if we look backwards at epidemiologic observational studies and meta-analyses, some have shown an increase in MACE on testosterone therapy, including the Vignan and Finkel study. These are pretty popular studies that have gotten a lot of press. A number of also high-profile studies have shown a decrease in MACEs, including the Shores and Jones study, which got a lot of press, and others have shown a neutral or no net effect of MACEs with testosterone therapy. So the jury is still out. We need to tell our patients that it's not clear what impact testosterone therapy will have on future risk of cardiac events. And so for this reason, it's important to, tell our patients that their current literature does not definitely demonstrate that testosterone therapy increases the risk of MACEs, because patients want to know, if I go on therapy, is this going to cause me to have heart attacks? And so, given the lack of clear cause, we do prescribe this therapy for our patients, but it's in the caveat or with the caveat of having our patients report the occurrence of any possible cardiovascular symptoms. That includes chest pain, shortness of breath, dizziness, loss of consciousness, and so forth. And certainly if these occur during, time between visits, we tell our patients, stop the therapy and call us and let's talk about what to do regarding your treatment. So this patient started on testosterone therapy, and 6 months later, he finds that he's had improvement in his low libido, his concerns over obesity, his low energy, and his depressive symptoms. His blood work all improves. His weight continues to drop. He's down to 200 pounds now. His BMI and waist circumference accordingly have also improved. His testosterone level is now up. Remember, it was 280. Now it's at 750. His hematocrit, though, is now at 54, and this is above the reference range. So the question is now, what is the next step in this patient's management? And so the guidelines state that when a patient develops polycythemia on testosterone replacement therapy, the patient should have a decrease or a drop in the dosage. And I point out that in some instances, we'll even stop the therapy altogether if the hematocrit is markedly elevated. Another important teaching point here, or point for consideration, is that even before starting testosterone therapy, it's a good idea to get a baseline H&H level to know what the patient's starting point is. Now, their literature has also commented on the incidence of venothrombotic events, or these VTEs. If you look at the product insert for testosterone therapy products, there is a warning statement about an increased risk of these VTEs with testosterone therapy. But, the panel felt at the time of looking at all the cumulative literature, at the time of the guidelines panel being convened, that really there was not definitive evidence linking testosterone therapy to a higher incidence of these venothrombotic events. So the warning is still in there in the product insert, but the guidelines panel just felt that there wasn't compelling evidence linking the two. And so, our patient does well, and 10 years later, he comes back with unstable angina. He has an angiography revealing single vessel disease, and he has a stent placed. What should be done with his testosterone therapy now? And the guidelines advise that the testosterone should be held for 3 to 6 months after a cardiovascular event. And, there's a lot of conversation about this point. There's really not firm guidance in the existing literature on how to proceed. And the panel felt that this timeline was safe enough to allow recovery from whatever cardiac event had gone on, and also time to allow observation, a little bit of prospective observation, to make sure that the patient wasn't incurring worsening overall health status in this period of time. So when someone has a cardiac event, we'll usually hold therapy for that 3 to 6 month window. So some key takeaway points on testosterone and cardiovascular disease risk. One, low testosterone is a risk factor for cardiovascular events. Therapeutic lifestyle interventions should be considered or recommended as an initial treatment for low testosterone. Many of our patients don't have the patience to take us up on number two, but patients can definitely make progress on the low testosterone with this approach, and it helps their overall health as well. 3, the cardiovascular risk and benefits of testosterone therapy in men with symptomatic low testosterone remain uncertain. 4, there's no clear evidence that venous thrombotic risk with testosterone therapy exists, but polycythemia is a very real thing and should be avoided. And again, as we're tracking our patients over time, we want to make sure to track their hemoglobin and hematocrit. And finally, there's really not enough evidence at this point in time to support a guideline for testosterone treatment of men with recent cardiovascular disease events. And for now, the 3 to 6 month timeline of holding therapy or pausing therapy after an event seems to be pretty prudent. So I want to switch gears now, talk about testosterone and male fertility. And so we're going to frame this this topic in a case. And what we have is a 26-year-old man who presents with many years history of low sex drive, poor response to working out regularly, and an increase in central adiposity. And he wonders if he should have a testosterone level checked. He has no prior medical or surgical history. He's not on any meds. He's a young guy. He's newly married and has a pretty healthy lifestyle. So on exam, he's tall. He's 6'3". He weighs 190 pounds. He has no gynecomastia, but he does have bilateral testicular atrophy. The rest of his scrotal exam is normal. He undergoes laboratory testing, and his early morning testosterone level comes back at 200 nanograms per deciliter, which is low. And when he gets these results, he wants to know, can I start testosterone therapy? He's read a lot about it and wants to get on therapy. Well, for us, the clinicians, what is the next step in his management? Well, as a next step, we should measure his serum luteinizing hormone, or LH level. And this is important because it's going to allow us as clinicians to establish the etiology of testosterone deficiency and also to determine if other adjunctive tests are needed. And so the idea here is if a patient has very low LH, then it is likely that there is a hypothalamus and or pituitary issue at heart, in other words, secondary hypogonadism. And if the LH level is normal or elevated, that's going to indicate or point towards primary hypogonadism or an intrinsic testicular issue. And so the guidelines provide this information in a table, which we have referenced down here. I'm going to refer to this now. So the patient goes for a repeat testosterone level, as we discussed, and this level also comes back unequivocally low at 190. And his serum LH level comes back low at 0.7. So this patient has low testosterone and low LH, indicative of hypogonadotropic hypogonadism. So during the follow-up visit where these results are being discussed, he states that he and his wife want to begin efforts to conceive in 6 months. And what the guidelines document states is that for patients who are interested in preserving their fertility in the setting of low testosterone, they should also be offered FSH testing. And so that is sent off on this patient, and perhaps not surprisingly, just as the LH level was low, so is the FSH level, really again pointing to a hypothalamic or pituitary issue. And so this is a 26-year-old male with hypogonadotropic hypogonadism who's going to begin efforts to conceive in 6 months. What's the next step in the management of his low testosterone? Well, the guidelines state that a reproductive health evaluation should be performed as the next step, and that adjunctive testing should be considered, adjunctive fertility testing, such as a semen analysis. And so he goes for semen testing, and both of his semen tests show normal ejaculate volume, azoospermia. So there's no sperm in the ejaculate in this man with hypogonadotropic hypogonadism. What's the next step now in his care? Well, the guidelines emphatically state that exogenous testosterone therapy should not be prescribed to these patients who are trying to currently conceive. Exogenous testosterone has inhibitory effects on the production of intratesticular testosterone, which is essential to maintain normal spermatogenesis. Also, exogenous testosterone can lead to severe oligospermia or lasting azoospermia. So then what are the treatment options for the management of his low testosterone and fertility concerns? Well, the guideline statement number 27 addresses a specific issue and points out that clinicians can use aromatase inhibitors, HCG, or SERMs such as Clomid, or a combination of these medicines in men with testosterone deficiency desiring to maintain their fertility. So these agents are commonly used to promote endogenous testosterone production. And it's important to note that while they share the same overall treatment effect, namely improving testosterone, they do have substantial differences in that they work by different mechanisms of action. And that's why they can be added onto one another and work synergistically to improve testosterone. So these medicines, to talk a little bit more about them, aromatase inhibitors block the conversion of testosterone to estradiol. And this leads to a net increase in testosterone levels due to, number one, a decrease in the conversion of T to E2, and also a drop in the estradiol negative feedback at the pituitary gland. The end result here is that LH levels go up, and that drives testosterone production. HCG is an LH agonist. In other words, this directly stimulates Leydig cells to secrete testosterone, pretty straightforward. And finally, SERMs, such as clomiphene citrate, block pituitary estradiol receptors, and therefore they block estradiol's negative feedback at the level of the pituitary gland. Therefore, LH production increases. This in turn stimulates Leydig cells to make testosterone. So after discussing his options, he elects to start the HCG therapy, and after 3 months on HCG, his total testosterone level is normalized to 500. He has a very good response. His testosterone deficiency symptoms, which included diminished libido and low muscle mass, improve. And sequential semen testing at 3 and 6 months after the initiation of therapy show that he now has a sperm concentration in the low normal range, which is a typical response for men who have a history of HH who are treated with this type of therapy. So the couple begins timed intercourse using an ovulation detection kit, and they conceive successfully by natural means 9 months after he started the HCG, and they have a healthy son born at term. So I'm going to turn it over for a moment to Dr. Halpern to provide some comments or thoughts about men who are on testosterone therapy or men who have low testosterone who come in to see him as a clinician. And we thought we'd actually frame this in the context of a man already on testosterone therapy who comes in and is struggling with fertility issues.
Yeah, well, this is a really interesting case, and certainly a little bit different when we think about hypogonadotropic hypogonadism as we're seeing here compared to the guys who are coming in on testosterone. But I think that slide that you presented before showing kind of what our toolbox looks like, whether it's aromatase inhibitors, Clomid, and HCG, these are really kind of the tricks of the trade, and there's a lot of different ways to approach that. I think, with these guys who have hypogonadotropic hypogonadism, oftentimes they functionally don't really have a working pituitary, and so something like Clomid exerting that negative feedback and the selective estrogen receptor modulator is not going to be effective. You really need something like HCG, whereas sometimes, when the guys come in on testosterone replacement therapy, and I think we'll probably chat about that a little bit down the road in this talk, sometimes those guys might be a little bit more likely to respond to Clomid or to use Clomid as an adjunct to something like HCG or an aromatase inhibitor.
Yeah, those are all really good points. And so, there are a number of options, and some of this is going to boil down to accessibility of the medications, some of it patient preference, and some of it cost for the patient. But certainly we just see so many of our patients who are on exogenous testosterone therapy coming in, and we really just continue to try to spread the word that this therapy, as the guidelines point out, should be avoided. And if a man has low testosterone, starting up front with one of these alternative therapies often gives them very good clinical response. Okay, so, testosterone fertility, here are the key points from the guidelines. 1, men with testosterone deficiency who are interested in fertility should have a reproductive health evaluation performed prior to treatment. Serum LH levels can help to establish the etiology of testosterone deficiency and determine if adjunctive tests are needed. And those adjunctive tests, may include things such as a serum FSH level or semen testing. So adjunctive testing, including FSH, estradiol, and karyotype, should be ordered in special cases of men, such as men interested in fertility. If a man has gynecomastia, estradiol should be ordered. And finally, if a man has unexplained hypergonadotropic hypogonadism, we should really think about obtaining a karyotype on the patient. 1 in 650 men are affected by Klinefelter syndrome, and these men will very often present to the urologist with complaints of symptoms of testosterone deficiency, and it's often the urologist who's making this diagnosis. Number 4, exogenous testosterone therapy should not be prescribed to men who are currently trying to conceive. 5, alternative therapies, including aromatase inhibitors, HCG, and SERMs, such as clomiphene citrate, can be used in men with testosterone deficiency who want to maintain their future fertility. And finally, 6, the long-term impact of exogenous testosterone on spermatogenesis should be discussed with patients who are interested in future fertility. Namely, testosterone therapy can suppress spermatogenesis, can cause testicular atrophy, and in some men may result in permanent and irreversible azoospermia and infertility. We're going to switch gears now and talk a little bit about testosterone and prostate cancer. And so, at the recent meeting here in Chicago in April, the AUA released updated guidelines on the early detection of prostate cancer. And it's important for us all to keep this guidance in mind as we're working with our patients on testosterone therapy. 2 of the updated statements state, 1, that clinicians may begin prostate cancer screening and offer a baseline serum PSA test to people between ages 45 and 50 years of age. And previously, the age range there was a little bit younger. It was, just a bit younger. But the second statement is clinicians should offer prostate cancer screening age 40 to 45 years for people at increased risk of developing prostate cancer based on the following factors: Black ancestry, germline mutations, and a strong family history of prostate cancer. I think for all of us who see these patients, there's this notion of shared decision making. And, I think that the guidelines provide reasonable or sensible advice or guidance on when to start checking for PSA. But lots of times this just comes down to the comfort level of the patient before starting testosterone therapy. So the guideline statement also says that PSA should be measured in men over 40 years of age prior to commencement of testosterone therapy. So this is a statement coming from the Testosterone Deficiency Guidelines, and it'll be interesting to see if, as this guidelines document, the testosterone deficiency document is updated, if this number is altered given the recent change in the screening for prostate cancer document that we just talked about. Guideline statement number 17, clinicians should inform patients of the absence of evidence linking testosterone therapy to the development of prostate cancer. So our patients are very often concerned about this. Hey, doctor, if I go on this therapy, am I going to get prostate cancer? And so at this point in time, there really is not clear evidence linking testosterone therapy to the development of prostate cancer. We do know if prostate cancer is present, certainly the testosterone can support the growth of prostate cancer. And I think it's a nuanced discussion with our patients, but certainly, helpful to have this guidelines statement as backing about where things stand right now with the state of the literature. Guideline statement 18 states that patients with testosterone deficiency and a history of prostate cancer should be informed that there is inadequate evidence to quantify the risk to benefit ratio of testosterone therapy. And so, sometimes our patients, again, will ask nuanced questions. I've got a history of prostate cancer, I've been treated, or maybe I'm on active surveillance. What's going to happen to me if I go on therapy? And so we want to dig into this a little bit more because I think this is something that we see a lot clinically. And, my colleagues who are on the call, Dr. Bennett, I think may want to weigh in a little bit on this, and also Dr. Halpern. And, we'll just start out with an example. So a case of a 55-year-old male was a history of undergoing a robotic prostatectomy. He had Gleason's 4+4 in the specimen. His margins are all negative. He has no evidence of disease. And he sees you. He has, symptomatic testosterone deficiency. are you going to treat him? He's pushing for treatment. Dr. Bennett or Dr. Halpern?
Yeah,
Dr.
absolutely.
Bennett.
This is Dr. Bennett. Yeah, absolutely. I'm going to treat this man. Although that his Gleason score is 4+4, he does have negative margins, and his prostate is gone. It's out. If he is symptomatic, then we treat him with just testosterone supplementation, with the caveat that he would need to have PSAs probably more frequently, every 3 months instead of every 6 or once a year. And then he comes into the office at least twice a year for evaluation. But yeah, I have no issue treating a man like this. Now, there are a couple instances. Let's say if the patient is previously on testosterone and they get the diagnosis of prostate cancer, what do you do in that situation? In my clinic, what we recommend is we stop the testosterone, refer them over for surgery or whatever treatment they're going to have, and then resume the testosterone therapy if they are very symptomatic soon after their procedure, or if they're not very symptomatic, we wait a period of time between 12 and 18 months before restarting it.
That's excellent. Thanks, Dr. Bennett. Dr. Halpern, do you have any thoughts or anything to add to that?
Yeah, I totally agree. I mean, I think the way that I try to explain this to patients is that, there's really not a huge difference, in rendering somebody eugonadal, whether with testosterone replacement therapy as compared to somebody being endogenously eugonadal. So there are all these guys out there who undergo robotic prostatectomy with Gleason 4+4 disease who have normal testosterone levels, and we're not putting them on androgen deprivation therapy for fear that their, kind of mid-range endogenous testosterone is going to put them at risk of having blossoming disease. And so for the guy who's sitting in my office with a T of 150, we don't really have a lot of great evidence to suggest that if we render him eugonadal and get him up to the 300s, 400s, that he's going to have any more of a problem. But I do, kind of treat these guys a little bit more conservatively. So rather than aim for the middle tertile, sometimes I try to aim to get them maybe a little bit lower in the therapeutic range. Sometimes, I err towards and push towards using gels rather than injections. Maybe that kind of spike in testosterone that we're seeing from injections, especially if guys are on a higher dose every 2 weeks, maybe that is not great for, for kind of the prostate cancer. Although, again, newer data would suggest that, that may not be the case. So I totally agree. I think treating these guys is very, very reasonable. But I do tweak kind of my approach just a little bit.
That's great. Very, very helpful. Well, when we look at the second case here, and this is a 70-year-old male who received radiation therapy, external beam radiation therapy for Gleason's 3+4 disease. Let's call it multifocal bilateral disease. And say he's, 4 years out from his treatment, his PSA is 2. Dr. Bennett, how are you going to approach this gentleman? He still has his prostate gland in there. He had high-grade prostate cancer. He elected for radiation treatment. And he's sitting with a PSA that's, not low, but it's not super high either. And let's call it stable at 2.
Yeah, these patients scare me because they do have a prostate in place, and we're not exactly sure if their XRT got all of the or killed all the prostate cells. Obviously, it didn't if his PSA is 2.0. But I do treat these guys if they're symptomatic. I do sit down with them and really tell them they're going to need to have frequent PSAs, and they're going to need to have frequent DREs. And if their PSA budges or increases, then we will stop the testosterone and get his prostate issue sorted before resuming it.
Excellent. Dr. Halpern?
Yeah, I agree. This is a little bit more challenging in somebody who's got radiation therapy with a PSA of 2. I mean, there's a number of different ways to look at what is considered kind of recurrence after radiation. We only have one value for this guy. We don't know what his nadir was. We don't really know kind of the timeline, but I think these are the guys for whom really a multidisciplinary approach ends up being key. And so, touching base with a radiation oncologist, trying to understand first and foremost, is this guy going to need some sort of salvage therapy? And if that's not the case, then I think a thoughtful discussion with the patient and his other providers about about what's reasonable. But, to what my point with regards to prostatectomy, that we don't put men on androgen deprivation therapy to render them, hypogonadal or castrate after prostate cancer surgery. We actually do give androgen deprivation therapy along with radiation. And so, it's really not quite the same circumstance. So totally agree with Dr. Bennett. This gives me a little bit more pause. And I think getting a few more minds involved in the conversation is usually really helpful.
Excellent. Thank you. All right. So our third and final case on prostate cancer and low testosterone. So we have a 65-year-old male who's on active surveillance for Gleason's 4+3. And let's say he has, just a unifocal disease picked up on a biopsy. PSA is stable at 4. He's been followed for a couple of years. He's bothersome. He's got a young bride. He is interested in, maintaining a good intimate relationship with her. His libido's down. He's got some ED, but he also has Gleason's 4+3. So, Dr. Bennett, what are you going to do for this patient?
I will, after sitting down and talking with him, I would like to treat him with shorter acting testosterone agents, topical gels, or maybe even injections. Definitely not long acting pellets or long acting injections for this guy. This kind of wades into the arena that Dr. Halpern was talking about, where we do not track down men with normal testosterone levels and make them hypogonadal, just to prevent progression of prostate cancer. The 65-year-old active guy on active surveillance, has an active lifestyle and most likely will benefit from the testosterone therapy. He would have to commit to frequent PSAs, frequent exams, and biopsies as well. But we treat him.
Dr. Halpern?
Yeah, totally agree. I think, when we put guys on active surveillance, we do so with the understanding that the underlying premise is that we don't think their disease is at high risk for blossoming, and that goes, with or without testosterone replacement therapy. So these guys are going to get watched closely anyways. They're probably going to have surveillance biopsies. They're going to be on a pretty strict regimen. And so I think the chance that you miss, disease that's finding its way into more dire circumstances is really unlikely. So I totally agree with Dr. Bennett. I treat these guys, but same principles apply, kind of shorter acting, more stable agents, keeping close tabs on them.
Dr. Bennett, medical legally for patients such as these three here, anything regarding the charting or documentation about, the risk, your conversation with the patient? How do you handle that when you're, wrapping up after the encounter and documenting your, what's transpired?
We talk about, when we sit down and talk with these guys, I discuss the risk of prostate cancer coming back or blossoming. We talk about the need for frequent PSAs and prostate cancer screening. We also talk about polycythemia and treatment or reducing the therapy if that is the case. We document that the patient and I had the conversation, that they understand that there is a increased risk of rapidly developing prostate cancer on testosterone, and they have agreed to accept this risk, and they have to accept the fact that they need to come in for regular treatment. So I document that altogether.
Okay. Dr. Halpern.
Yeah, I totally agree. Sometimes I even reference the AUA guidelines because I think the AUA guidelines are really thoughtful in a lot of these areas of testosterone treatment, but kind of referencing the fact that the data on this is equivocal, and there's not really enough data to really give us tremendous guidance as to where we should go. I mean, I think even these case presentations illustrate just how far we've come in the last few years. Just a few years ago, giving testosterone to any of these patients would have been considered an absolute, contraindication. And yet here we are kind of cautiously offering them testosterone replacement therapy. And so I think really just documenting, again, that shared decision-making, like you referenced, Dr. Brannigan, when it comes to PSA screening. I think this is also an area for shared decision-making. And as Dr. Bennett said, making sure that you really articulate that they understand the potential risks. And then I think that really is a green light to move forward.
And just in closing on this topic, any anecdotal reports from either of you where you had such a patient and PSA was going up, there's other clinical evidence or laboratory evidence of concerning findings, PSA skyrocketing up or other issues?
I've had one 72-year-old patient. He was on active surveillance. I think it was grade group 2, pretty low risk. PSA was under 5, and he elected to continue his existing testosterone therapy. And after about 6 months, his PSA went up by 1 point, and then he didn't want to come off therapy at that point, just wanted to watch it. His PSA 3 months later went up another point. At that point, we had stopped the testosterone and referred him back for treatment, proactive treatment.
Interesting. Dr. Halpern.
The short answer is no. I don't have any patients that have really run into trouble. I think that I have an increasing number of patients who are, would meet these criteria as prostate cancer patients, those on active surveillance or recently treated. So I think, my experience is still growing with these patients, but I've yet to have somebody who really ran into an issue, which I think is anecdotally very reassuring.
Excellent. Well, that brings us to the end of our time here for this webinar. I just want to thank all of you for the opportunity to visit today and to get a flavor for what our weekly Andrology conferences are like. Certainly invite you to keep an eye out for the next quarterly advances meeting, which will be announced shortly. Look forward to seeing you then, and certainly look forward to any comments, questions that you might have. We're all readily available here at Northwestern and would certainly be happy to curbside with you about your patients or help in the care of your patients. Thank you.
Dr. Brannigan, if I could ask a question.
Oh, sure.
Yeah, this was regarding polycythemia. The guidelines basically say to decrease the testosterone supplementation dose with when polycythemia occurs. But I was wondering what cutoff is normally used, and what cutoff do you use for your polycythemia treatment?
Well, yeah, thanks, Dr. Bennett. So, I think after a lot of thoughtful discussion with hematologists here and at other institutions, once someone rises above 54, that's where hematologists start sending patients for therapeutic phlebotomy. And, that's certainly, a cut point that we, look at with great concern when someone gets to that point or higher. For many, if not most labs, the cut point for hematocrit's around 50. But once it rises above 54, that's kind of the cut point for me in my practice. Dr. Halpern, does that match your approach? And Dr. Bennett, what is your approach on this?
My approach is I get concerned at 52%, and at 54 I refer them for therapeutic phlebotomy. I did have one patient come in when we tested his hematocrit. It was 60, and in that case, I immediately stopped his testosterone and referred him for therapeutic phlebotomy. But
it's
54
really high.
is my 60 was way too high, but 54 is my cutoff as well.
Yeah, excellent. Dr. Halpern, anything to add to that?
No, my practice is like Dr. Bennett said. At 52, I usually have them recheck earlier than I otherwise would. I don't let them go a full 6-9 months without a recheck, and then just make sure they're not creeping up.
Yeah, I mean, of all the parameters, this is the one that I actually have the most interest in and frankly concern for our patients. Certainly PSA we track, but this is the one that I do worry about and track the most closely. So thank you, Dr. Bennett, for that question. Any other questions or comments from Dr. Bennett or Dr. Halpern? Excellent. Well, I guess we will again close. Thank you so much for joining us today. And again, feel free to reach out to either Dr. Bennett, Dr. Halpern, me. Dr. Amar Sekra can be with us today, but certainly he's available to engage in discussion about these or other clinical issues related to andrology. Thanks again.